Hi, in this video I'm going to be talking about some of the basic physiology underlying the production of thyroid hormones T3 and T4, and some of the pharmacology that can also affect this process. So T3 and T4 are known as our thyroid hormones, and they have a number of effects around the body. These include the maturation of fetal brain and skeletons, and this means that you have to be very careful giving anti-thyroid medications to pregnant women. They increase your basal metabolic rate, which is why hyperthyroidism results in a very high basal metabolic rate, and so loss of weight, whereas hypothyroidism leads to gain of weight. And increased heart rate, increased force of heart contractions, and they stimulate gut motility. So these can help you understand some of the symptoms that are seen in hypo and hyperthyroidism. So the process of the production of thyroid hormones can be broken down into a number of steps. So initially, iodide is present outside of our thyroid parafollicular cell, and it's taken up by the cell via a sodium iodide transporter. Then we have the production of something called thyroglobulin, also sometimes written as Tg, and it's synthesized by the rough endoplasmic reticulum of our parafollicular thyroid cell. The iodide is then converted to iodine, and this iodine is then added to our thyroglobulin to create iodinated Tg. This is then stored in its colloidal form until it's required. And then once it's required, it's transported to lysosomes, which are present within the cell. These lysosomes then will break down our iodinated Tg to give back your iodine, and then various other things, including amino acids, T3 and T4, which are the things that we're looking for. These are our thyroid hormones, and MIT and DIT, which are two of the things that help come together to give us our thyroid hormones. So the MIT, DIT, and iodine can then be recycled because the MIT and DIT go back into the process of making up our thyroglobulin, and our iodine can then be recycled to again make iodinated Tg. And then we release our T3 and T4 into the bloodstream. So T3 is our very fast acting thyroid hormone, and T4 is very slow acting, but they overall have very similar effects. So this process can be seen here again in this diagram. So first we have iodide, which is present outside the cell, being taken in by a sodium iodide transporter. And then at the same time, we have the rough endoplasmic reticulum of the cell producing our thyroglobulin, or Tg. Now these steps are both mediated by cyclic AMP, or CAMP. Following this, we have our conversion of iodide to iodine, and then our iodine is added to our thyroglobulin to give iodinated Tg. And these two steps are both mediated by thyroid peroxidase, or TPO. And this is important because this is a target for our anti-thyroid medications. The iodinated Tg is then stored in its colloidal form until it's required, when it's delivered to a lysosome, which will break it down into our amino acids, our iodine, our MIT, and our DIT, and these can be recycled, and our T3 and T4, which are our thyroid hormones, where T3 is fast acting and T4 is slow acting. So, as I explained on the previous slide, we have our cyclic AMP, which mediates the process of the transport of iodide into the cell through the sodium iodide transporter, and the synthesis of our thyroglobulin by our rough endoplasmic reticulum. Then the thyroid peroxidase, or TPO, mediates the process of converting our iodide to iodine, and then adding the iodine to the Tg. So I remember that TPO acts on the steps involving the iodine, because it's iodide to iodine, and then adding iodine to the thyroglobulin. So the thyroid hormones then have to be transported throughout the body to their target tissues. Now, very little of this is transported through in the blood, and it's transported predominantly bound to serum proteins. The largest portion of this, 70 to 80%, is bound to thyroxine binding globulin, and then a good portion of the remaining T4 is bound to the thyroxine binding prealbumin. And then the rest of our thyroid hormone is transported in the blood bind to serum albumin, which may mean that if you have a low serum albumin, you have trouble transporting this thyroid hormone. So, as I mentioned earlier, we have our antithyroids, which can be given in cases of hyperthyroidism. So these inhibit TPO, which is our mediator of our processes involving our iodine. So you don't get the conversion of iodide to iodine, and then you don't get the iodination of our thyroglobulin. And if you don't have these processes, then you can't produce your T3 and T4. So the examples we have are carbimazole, which is often the first line, as it's more effective, and propylthiouracil. So carbimazole has a number of effects, including skin rashes, toxicity of the liver, and neutropenia. Propylthiouracil has similar side effects, but they're less common and often less severe. And as I mentioned at the start of the video, you have to be very careful giving antithyroids, and normally you don't give antithyroids to pregnant women because of the risk of preventing thyroid hormone in the fetus, meaning you don't get the maturation of the fetal brain and skeleton. If somebody has hypothyroidism, then you can give synthetic thyroid hormones. So we have levothyroxine, which is our synthetic T4. And this is the standard thing that will be given to people with hypothyroidism. Liothyronine is synthetic T3, and as we said, T3 is our fast-acting thyroid hormone. So we'd only give T3 in cases where the thyroid hormone level is so low that it's a medical emergency, as this will help to rapidly increase it, and then you can give long-term levothyroxine to ensure that it doesn't happen again. So that's a basic understanding of how thyroid hormones are produced and how the key medications interact with the process of thyroid hormone production. Thank you very much for listening.